leukocytes are the colorless and nucleated formed elements of blood. That is the term derived from leuko, that is a Greek word, means white. So that is why it's known as white blood cells. So if we compare the WBCs with the RBCs, the WBCs differs from RBCs in many aspects, like they are larger in size. The WBCs are larger in size, they are irregular in shape, and they are nucleated. The major important point is they are nucleated, and they are of many types. And there are granules are present in the cytoplasm of some of the WBCs, and their lifespan is very, actually very short comparing to RBCs, and sometimes it may live longer. Some WBCs may live longer, but on average, comparing to RBCs, its lifespan is shorter. So there are two types of WBCs. They are known as granulocytes and agranulocytes. So coming to the granulocytes, depending upon the staining property of the granules, the granulocytes are classified into three. They are neutrophil, eosinophil, and basophils. Neutrophils, which takes the stain, like both acidic and basic stains are taking up, and the eosinophil granules, which takes the acidic stain, eosin stain, and the basophils granules will take the basic stains or a basic stain that will take. And agranulocytes, which are comparatively it is plain, there is no much visible granules will be present. If it is present, that will be very minute. So that's why it is known as agranulocytes, which is almost plain cytoplasm without granule. There are two types, that is monocytes and lymphocytes. So the normal WBC count is around 4,000 to 11,000 cubic millimeter of blood, and the lifespan, as I said earlier, it is not constant. It depends on the demand in the body and their function. That means it varies within half day to around 6 months. So that's why on an average, comparing to RBC, it is shorter. And coming up to the size and the diameter of the WBCs, the neutrophils is having a size of 10 to 12 micron with a lifespan of 2 to 5 days. And eosinophil, again, it is 8 to 10 to 14 micron with a lifespan of 7 to 12 on average. Basophils are 8 to 10 micron in diameter, and it is of around 12 to 15 days of an average. And monocytes diameter is around 14 to 18 micron. These are the largest WBCs in the blood. So its lifespan is around 2 to 5 days. And lymphocytes, it varies. There are two types of lymphocytes according to the size. That is a small lymphocyte and large lymphocyte. Small lymphocyte will be the size of almost the size of an RBC, and large lymphocytes be around 10 to 13 micron diameter. So we can say the size of a lymphocyte will be around 7 to 12 micron, and the lifespan is very short, that is half to 1 day. So coming to the neutrophil, here you can see the diagram of a neutrophil. The neutrophil are polymorph, that is the cytoplasm contain fine granule. So the granules which takes both acidic and basic stains when we stains with the Leishman stain. So the granules appear under the microscope, it appear as violet in color. If you find beautiful granules will be there. And the nucleus is multi-lobed. So here what we have to remember is the number of lobes in the nucleus is which depends upon the age of the cell. Means if the cell is getting older, there will be more number of lobes will be there. And if a young cell means only 2 lobes will be appear. Sometimes it won't be lobe, just a crescent shaped nucleus can be seen. And the diameter of the cell is around 10 to 12 micron, and shows a amoeboid movement or amoeboid in nature. That means it will move to, according to the need, the neutrophil will move to the area in an amoeboid fashion. So its function, it plays an important role in the defense mechanism of the body. That is, along with monocytes, the neutrophils provide the first line of defense against the invading microorganism. So first line of defense, which is the most important point we have to remember about the neutrophil. So the neutrophils are the free cells in the body and wander freely through the tissues. And the substances secreted from the neutrophil are proteases, myeloperoxidases, elastase, and metalloproteinases, which helps in the destruction of the microorganism. And defensins, which helps in an antimicrobial action, anti-inflammatory action, wound healing, and also helps in chemotaxis. And cathelicidins, which is having an antimicrobial action, NADPH oxidases, which shows a bactericidal action, and platelet activating factor, which aggravates the platelets, so the aggregation of the platelets. So these are the substances which are produced from or secreted from the neutrophils. Coming to the eosinophils, just like this picture, these granules are coarse granules, that is larger granule, which stain pink or red with the eosin. And the nucleus is bilobed and it may be a spectacle-shaped nucleus, and the diameter is varies between 10 to 14 micron. It plays an important role in the defense against parasites, eosinophil count, that is the parasitic infestation. There is a production of large number of eosinophil, so which move toward the tissue and which is affected by the parasites, and the eosinophil count increases during parasitic infestation, also which increases during allergic reactions or allergic diseases like asthma. So the eosinophil, the major function of eosinophils are detoxification, disintegration, and removal of the foreign protein. Coming to the substances which are secreted from the eosinophil, they are eosinophil peroxidase, which helps in the destruction of worms, bacteria, and tumor cells. Major basic protein. Again, this one which helps in the destruction of worms. And eosinophil cationic protein. Again, it helps in the destruction of worms and neurotoxic action. And eosinophil derived neurotoxin, that again produces a neurotoxic action, and interleukin 4 and 5, which accelerate the inflammatory response and also help in the destruction of the invading microorganisms. So as a whole, the eosinophils, which helps in the destruction of the parasites, especially the worm infestations. Coming to the basophil, the cytoplasm of the basophils contain coarse granule, and the granules which stain purple blue with the methylene blue in the Leishman strain, and the nucleus is bilobe and the diameter is around 8 to 10 micron. Here in the structure, in the picture itself, we can see the cell is not, the nucleus is not clearly visible because the granules will completely mask the nucleus. So under microscope, it can be seen as a bunch of grapes. So the basophils plays an important role in the healing process. So their number increases during healing. After an infection or a wound, the healing process will be mediated by the basophils, and it also plays an important role in allergy or acute hypersensitivity reactions because of the presence of IgE receptor in the basophil membrane. So coming to the substances which are produced from the basophil, they are heparin and heparin, which prevent the intravascular blood clotting, and histamine, bradykinin, and serotonin, which helps in the production of acute hypersensitivity reactions, and proteases and myeloperoxidases, which helps in the destruction of microorganisms, and interleukin-4, which helps in the acceleration of inflammatory response and cause the destruction of the invading organism. So these are all about the granulocytes. Now let's see about the agranulocytes. Coming to monocytes, these are the largest leukocytes. Monocytes are the largest leukocytes with a diameter of 14 to 18 micron. And cytoplasm, the difference is here the cytoplasm looks as a frosty appearance, as a frosted glass appearance, we can say. And the nucleus is round, oval, and horseshoe shape. Any shape can be seen. Either it will be round, or it will be oval, or horseshoe shape, or bean shape, or kidney shape. And nucleus is placed either in the center of the cell or pushed to one side. And the most important characteristic is there is a large amount of cytoplasm will be visible. Comparing to the nucleus, the amount of cytoplasm will be more in monocytes. So they are the largest cells, and as I said earlier, like neutrophil, they are also, the monocytes are also motile and phagocytic, and they are free or wander freely through the tissues of the body. The substances which are secreted from the monocyte are interleukin-1, which help in the acceleration of inflammatory response and destruction of the invading organism, and colony stimulating factor, means which help in the formation of colony forming blastocytes, and platelet activating factor, which again help in the aggregation of platelet, and chemokines that helps in the chemotaxis. Coming to the lymphocytes, the cytoplasm which is having no granules. Nucleus is oval, bean-shaped, or kidney-shaped, and the important feature in monocytes are with the nucleus occupies the whole of the cytoplasm. Means a rim of cytoplasm may or may not be seen, especially in small lymphocytes. We can say that the small lymphocytes are, according to the structure, the lymphocytes are divided into small and large. Small lymphocytes as having a ink spot nucleus, means whole of the cytoplasm is covered by the nucleus. And in large lymphocytes, a small quantity of cytoplasm can be visible, but still the nucleus almost occupies the cytoplasm, whole of the cell. And the lymphocytes which plays a major role in the immunity. So it is classified into two. They are B lymphocytes and T lymphocytes. T lymphocytes are responsible for the development of the cellular immunity, and B lymphocytes are responsible for the development of humoral immunity. So the substances which are produced from the T lymphocytes are interleukin 2, 4, and 5, which helps in the acceleration of inflammatory response, destruction of the invading organism, and activation of the T cells. Coming to the gamma interferon, which helps in the stimulation of phagocytic actions of cytotoxic cells, macrophages, and natural killer cells. And lysosomal enzymes. Lysosomal enzymes helps in the destruction of the invading organisms. And tumor necrosis factor, which helps in the necrosis of the tumor, activation of the immune system, promotion of the inflammation. And chemokines, again, which helps in the chemotaxis. And the substances which are secreted from the B lymphocytes are the major important substances are immunoglobulins, which help in the destruction of the invading organism, and tumor necrosis factor, which necrotize the tumor, activates the immune system, and accelerate the inflammatory response. And the chemokines, which helps in the chemotaxis. So, according to the size, as I said earlier, the larger lymphocytes are younger cells with a diameter of 10 to 12 micron, and the small lymphocytes are the older cells with a diameter of 7 to 10 microns. And according to function, as we have seen it now, that is T lymphocytes with concerned with cellular immunity, and B lymphocytes are concerned with the humoral immunity. So let's see some conditions which are related with the WBCs, that is leukocytosis. That means there is an increase in the total WBC count that occurs in both physiological and pathological condition. That is, increase in WBC count is known as leukocytosis. Leukopenia is the decrease in the total WBC count. That is, this is generally used for the pathological condition, leukopenia. And granulocytosis. Granulocytosis means abnormal increase in the number of granulocytes. And granulocytopenia, that is the abnormal reduction in the number of granulocytes. And agranulocytosis means the acute pathological condition characterized by the absolute lack of granulocyte. So, coming to the variation or the physiological variation, WBC count is above around 20,000 per cubic millimeter in infants and about 10,000 to 15,000 per cubic millimeter in children. In adult, it ranges between 4,000 to 11,000 cells per cubic millimeter of blood. And there is a slight increase in WBC count in males comparing to females, and the minimum WBC count is showing in the early morning and maximum is seen in the afternoons. So now we can see the difference between three conditions like leukocytosis, leukemia, and leukopenia. Leukocytosis is the increase in total leukocyte count. That is during infection, allergy, common cold, or tuberculosis, or glandular fever, or whatever it is, there is an increase in total leukocyte count. But coming to the leukemia, that is a abnormal and uncontrolled leukocyte count. Moves more than 1 lakh cells per cubic millimeter of blood, and it is also known as blood cancer. Leukemia, that is uncontrolled or abnormal increase in WBC. And leukopenia, there is a decrease in WBC count, which occurs in the pathological conditions like anaphylactic shock, cirrhosis of pernicious anemia, typhoid and paratyphoid fever, and also in viral infections. So, coming to the properties of WBC, there are mainly 4 properties. They are diapedesis. Diapedesis is the process by which the leukocytes skews through the narrow blood vessels. Means whenever there is an emergency, the WBCs will skew through the minute capillaries to reach that particular area. An amoeboid movement. Neutrophils, monocytes, and lymphocytes, which movements like protrusion of the cytoplasm and change in shape and slowly move to that particular area. And the next property is chemotaxis. That is the attraction of WBCs towards the injured tissue by the chemical substances. The chemical substances are known as chemoattractants. The chemoattractants are released, and that will help to move the substances towards that particular area. And phagocytosis. The neutrophils and monocytes engulf the foreign bodies. This is the phagocytosis. Coming to the WBCs are formed from a mother cell that is known as the pluripotent stem cell. Pluripotent hemopoietic stem cells. From the pluripotent hemopoietic stem cell, the stem cell is divided into 2 types of cells. They are lymphoid stem cell and colony-forming blastocytes. From the lymphoid stem cells, the lymphocytes are arised by forming the lymphoblasts. So, from the lymphoid stem cell, lymphoblast, the lymphoid stem cells divides and form the lymphoblast, and this lymphoblast further divides and forms the lymphocytes. Coming to the colony-forming blastocytes. From the colony-forming blastocytes, different colonies of the blood cells will produce. That is, from the colony-forming unit E or the erythrocytes, RBCs will form. Colony-forming unit M or the megakaryocytes, platelets will derive. And from the colony-forming unit GM or the granulocyte and monocyte, we will get the WBCs. So, the colony-forming unit granulocytes and monocytes further divides to form myeloblast. This myeloblast again undergoes division, and we will get promyelocyte and monoblast. From promyelocyte, it further divides and differentiates to form neutrophil myelocyte, basophil myelocyte, and eosinophil myelocyte. From the neutrophil myelocyte, we will get neutrophil metamyelocyte. From neutrophil metamyelocyte, neutrophil. And from basophil myelocyte, we will get basophil metamyelocyte and basophil. And from eosinophil myelocyte, divides to form eosinophil metamyelocyte, and it forms the eosinophils. Coming to the monoblast, the monoblast cells, the black cell will divide to form pro-monocyte, and from the pro-monocyte we will get the monocyte. So this is about the WBCs, and now let's see about the blood groups. So before going to blood groups, we have to see a law that is known as the Landsteiner's law that states that if a particular agglutinogen or an antigen is present in the RBC, the corresponding agglutinin or the antibody must be absent in the serum. And if a particular agglutinogen is absent in the RBC, the corresponding agglutinin must be present in the serum. So, through the second part of, though the second part of law, in fact, it is not applicable to the RH factor. So, coming to the ABO system, before going to the ABO system, we have to see that there are so many type of blood group systems are present in the human race. They are like Yemen system, P system, Defi system, Kell system and all. But the most important blood group systems are ABO system and RH system. So we are going to talk about the ABO system and the RH system here. The ABO system, based on the presence or absence of antigen A and antigen B, the blood group system is divided into 4. They are A, B, AB, and O. So, in the A group, antigen is A and antibody is at B. So, the corresponding antibody is absent. And B blood group having antibody A and AB blood group which are having no antibodies, and O blood group which contains both A and B antibody in the serum. So the blood groups, we should know the blood group before blood transfusion, because only compatible blood, means same blood group only can be transferred. And the one who gives blood is known as a donor, and who receives blood is known as a recipient. The universal donor, the RBC of the O group having no antigen, and so agglutination doesn't occur with any other group of blood. So O negative, remember the O negative blood group can be given to any blood group person, so they are known as universal donors. And universal recipients, that is the AB positive blood group, because they are having both A and they don't have any antibodies. So they are known as the universal recipients which can receive any blood group. So before going to the blood transfusion, we have to do a matching and a cross matching to check whether the blood groups are compatible. For matching, we have to mix the recipient's RBC with the donor's serum. And for cross matching, we have to check whether the recipient's serum and the donor's RBCs are matching. So, coming to the transfusion reactions due to ABO incompatibility, there are the transfusion reactions are the adverse reactions in the body which occur due to the transfusion error, which involve transfusion of the incompatible blood. The severity varies from mild to severe, and it depends upon the amount of blood transfused and the reaction and general health of the patient. And it is due to the hemolytic reactions because the antibodies, the recipient's antibody like IgG or IgM adhere to the donor's RBC and get agglutinated and destroyed. So large amount of free hemoglobin is liberated and leads to transfusion reactions. So there are two types of transfusion reactions. They are non-hemolytic reaction and hemolytic reactions. The hemolytic reactions are of two types. They are acute and delayed hemolytic reactions. The non-hemolytic reactions, which develop within a few minutes to hours, and they are like fever, difficulty in breathing and itching. The hemolytic reactions, the acute, that is means within few minutes, they develop rapid hemolysis of the RBC. Like we will get the symptoms like fever, chills, heart rate, increase in heart rate, low BP, shortness of breath, bronchospasm, nausea, vomiting, and red urine or hematuria, chest pain, back pain, and rigor. Some may develop pulmonary edema and congestive cardiac failure. And the delayed reaction, which occurs around 1 to 5 days after transfusion, that because the hemolysis results in release of large amount of hemoglobin, and this large amount of hemoglobin which may clog the small minute blood vessels of heart and or the vital organs like our heart and lungs or even the kidney renals. So that may lead to jaundice, cardiac shock, and the renal shutdown. So the hemoglobin released from the destroyed RBC is degraded and bilirubin is formed. So the serum bilirubin level increases about 2 milligram per deciliter. Then we will get jaundice. And the hemoglobin, which is released into the plasma, which increases the viscosity of the blood. So increase in viscosity, which leads to increase in workload of the heart and may leads to heart failure. And the toxic substances from the hemolyzed cells causing the constriction of the blood vessels in the renals, causing anuria. Also, the hemoglobin will lose through the urine, causes hematuria and hemoglobinuria. So, if you are not doing dialysis as early as, the person may die within 10 to 12 days because of jaundice, circulatory shock, and also due to the renal shutdown and anuria. Coming to the RH factor. RH factor, that is an antigen present in the RBC, which is discovered by the Landsteiner and Wiener. And it is first discovered in rhesus monkeys, so the name is known as RH factor. And the person having the antigen is known as RH positive, and without the antigen are known as RH negative. So, if we are RH compatibility or the positive and negative incompatibility, that leads to transfusion reactions due to RH incompatibility, means in an RH negative person receives RH positive blood, he is not affected for the first time. For first time, there is not much reaction, and they may produce some delayed response, but sometimes it may not be that severe. And the antibodies against the blood group or the RH will be developed in the person for a longer period or forever. So the person receives Rh positive. For the second time, the donor's RBCs are get agglutinated and there will be severe transfusion reactions. So, for the first transfusion, there won't be much complications, but Rh antibody is produced. Coming to the second transfusion, the Rh antigen reacts severe and immediate response will be there with severe agglutination, and the condition known as erythroblastosis fetalis, that is the disorder in fetus where the presence of erythroblast, that is the immature RBCs in the blood. This will happen when the mother of Rh negative and the fetus is Rh positive. And once the first child escapes the complication of the Rh compatibility, because the Rh antigen cannot pass from fetal blood into the mother's blood through the placental barrier. But at the time of parturition, the Rh antigen from the fetal blood may leak into mother's blood and leads to placental detachment. And in the postpartum period, that is within a month after delivery, the mother develops Rh antibody in her blood. So, if the mother conceives for the second time, and if the fetus happens to be Rh positive again, the Rh antibody from mother's blood crosses the placental barrier and enters the fetal blood. So, the Rh antigen cannot cross the placental barrier, whereas the antibody can cross it. So the Rh antibody, which enters the fetus and causes agglutination of the fetus RBCs, resulting in hemolysis, leads to severe anemia, hydropus fetalis, and kernicterus. So to treat that, we have to introduce anti-Rh antibodies. Means if the fetus happens to be Rh positive in an Rh negative mother, immediately after delivery, we have to introduce anti-Rh antibodies to treat that particular condition. So by this, we finished our blood groups, and next we can see about the immunity in the next class. Thank you.